So, good morning, everyone. So, today, me and my group gonna present a case in front of you all. And so, the case we have is a 55-year-old man with abdominal pain, joint swelling, and the skin lesion. The chief complaint is a patient, 55-year-old man, was transferred to this hospital from a rehabilitation facility because of abdominal pain and a painful skin lesion. So the history of a present illness. So we have a patient with a periumbilical and a right lower abdominal pain with no fever, nausea, vomiting of joint pains, and he also reported 5 days of painful skin lesions and swelling of the right leg. So while observing closely, there was a pitting edema in the right foot and a blanching erythematous inducted plaque of around 5 centimeter in diameter, with superficial scale was present on the right knee, which you can see in the figure here, and there were other two plaques of 1 centimeter diameter present on the lateral side of the calves. So you can see here, and there were several non-tender hyperpigmented patches on the lower legs, and they were consistent with a post-inflammatory hyperpigmentation, and there was pain also on palpitations and diffuse erythema and warmth of the right lower calf. Past medical history we have, when the 1 year before patient admission. So the patient was diagnosed with a pancreatitis, and after MRCP performed for the evaluation of a chronic abdominal pain, revealed pancreatic necrosis. So the patient was treated with bevacizumab therapy until his blood lipase level elevated. Then the treatment was discontinued. 7 months before patient admissions, another MRCP showed pancreatic ductal dilations and a pancreatic pseudosis with internal calcification, and the endoscopic ultrasonography revealed changes consistent with chronic pancreatitis and a pancreatic pseudosis. So the patient was advised to continue and avoid alcohols and fatty foods. Then again, his blood lipase level returned to the normal. Then 3.5 months before admissions, he continued with a pain in his ankles, and the pain get was after prolonged rest. That his ankle felt stiff after he walked in the morning. So, and after 2 weeks, these there were pain and the redness and the swelling in the left lower leg with a central flexion nodule on an erythematous base. So you can see in the figure A over here. So over the next 2 weeks, he noticed swelling and redness of the left fifth toe and right right first metacarpophalangeal joint, and which you can see in these figures B and C over here. So he was treated with a cephalexin, and after several days, his condition had not improved, and he was diagnosed with a possible Lofgren syndromes, and then peridinizone was prescribed for him, which really helped him in getting relief. Then 5 weeks before the admission, the patient was admitted with a septic shock and a hemorrhagic shock cen- in the context of infected pancreatic necrosis, and there was bleeding from a gastroduodenal artery pseudoaneurysm. So the patient also has some other medical history, hypertension, neurofibromatosis type 2, gastroesophageal reflux disease, sensorineural hearing loss, benign prostatic hypertrophy, and anxieties. And the medication he was on was aspirin, gabapentin, hydrochlorothiazide, lorazepam, losartan, metoprolol, omeprazole, oxycodone, pancrelipase, prednisone, tamsulosin, and tolterodine. These are some physical examination vital signs over here. And the temperature is 37.3 degrees Celsius. Heart rate is 118 beat per minute, which is a little bit increased. Blood pressure is 107 by 68 mmHg, which is a low. And respiratory rate is 20 beats per minute, which is normal. And O2 saturation is 90% on ambient air, which is normal. And now family and social history we have for this patient is a patient was a heavy alcohol abuser, but the patient had stopped drinking alcohol like 3 years ago, and he lived with his mother in a suburban area. And he had a history of tobacco use, and but there was no history of electric use. Okay.
So I'll be starting from the labs. So as we can see here, we see that the patient is anemic. We see that his white cell count is slightly high, and also his lipase levels are really high. Um, Albumin is also a bit low too. Next slide, please. So I'll start with the diagnostic process. So we know that the patient's chief complaint is abdominal pain, joint swelling, and skin lesions. The possible cause of the abdominal pain will be the pancreatitis that he was diagnosed with earlier. So now we'll be talking about the possible causes of the joint swelling and skin lesions. We'll be looking at four possible causes. That's vasculitis, cancer, infection, and panicolitis. Next slide. So firstly, is it due to vasculitis? Vasculitis is the inflammation of small or medium-sized vessels, and they usually present with dermatologic presentation. And often during in vasculitis, the size of the skin lesion is it correlates with the size of the vessel that is inflamed. For example, in Oxline purpura, which is inflammation of small vessels, they usually present as a crop of small and palpable purpura, but this is not seen in this case. Also, in this patient's case is similar to a medium vessel vasculitis, for example, polyarthritis nodosa. But however, in this case, we are not seeing the rash as a livedo reticularis type, where you see a net-like, lace-like purplish rash in the legs. We also don't have any sign of hepatitis B seropositivity. The patient also didn't complain of any testicular pain or weight loss. Next slide, please. So, secondly, is it due to cancer? Uh, Subcutaneous panicolitis, like T cell lymphoma, is rare cutaneous lymphoma of the T cell, and it can mimic inflammatory skin disorders. The disorder usually presents with skin lesions that present as plagues and patches on the legs. But in this case, we didn't see that we have tender nodules, not patches and plagues. Also, in this type of cancer, is usually associated with women commonly, and usually coexist with conditions like lupus, multiple sclerosis, and hypothyroidism. And the nodules are usually painless. But in this case, the patient's rash and nodule was painful. So we can exclude cancer as the diagnosis in this case. Next slide, please. Thirdly, is it due to infection? Maybe cellulitis probably due to a bacterial infection. Uh, Patients with cellulitis usually present with unilateral diffuse and demarcated tender erythema. But in this patient, he had bilateral tender nodules that even persisted when they treated him with cefalexin and ceftriaxone. So that way we could exclude cellulitis as an unlikely diagnosis, because if it was cellulitis after treatment with antibiotics, there will be some kind of improvement, but there was no improvement. Uh, is it due to a fungal infection? Because the patient was immunocompromised due to his poor health condition and also used prednisone, fungal infection might be suspected. Next slide, please. For example, candidiasis is the lead causing cause of mycosis associated death in the US. And the patient had risk factors such as the GI infection, he had the recent catheter use, and also the recent use of bevacizumab. But in this patient, usually patients with candida present with gangrenous lesions and oral thrush, which was not seen in this patient. Also, the intra-abdominal fluid they obtained from the patient did not even grow any candida species, so we can exclude candida too as also a likely diagnosis in this case. Next slide, please. Finally, is it due to panicolitis? Panicolitis is the inflammation of a subcutaneous fat, and it can result from multiple causes, e.g., bacteria, viruses, fungi, or inflammatory diseases. So firstly, we look at Lofgren syndrome. The patient was treated with prednisone for possible Lofgren syndrome, and Lofgren syndrome is characterized as it usually presents with classic triad of erythema nodosum, hilar leaf adenopathy, and acute polyarthritis. But in this patient, the patient had a normal chest radiography, so there was no evidence of hilar lymphadenopathy. The lesion of the patient was also a fluorescent nodule on a red base, which was not consistent with erythema nodosum. So Lofgren's syndrome can be is unlikely in this case. Next slide, please. Second, is it due to lupus paniculatis? Because the patient's inflammatory markers were elevated, such as the erythrocyte segmentation rate and CRP were elevated, we could suspect lupus. But in this case, lupus is common in women and is characterized by nodules and plaques on the face, arm, trunks, and not legs. In this case, the patient's skin lesions were confined to the legs, so we could exclude lupus paniculatis as also not a likely diagnosis in this case. Next slide, please. Finally, pancreatic paniculatis. Since the patient it was diagnosed early for chronic pancreatitis, we could suspect pancreatitis paniculatis. Uh, Patients with this disease usually present with tender, fluorescent subcutaneous nodules that usually involve the legs, and which was seen in this patient. Also, the patients with this disease usually present with pancreatic pseudocysts and polyarthritis, both of which were also seen in this patient. Therefore, I would think maybe like in this case, the diagnosis would be pancreatic paniculatis because of the patient's history of pancreatitis. Next slide, please. So, just a short info about pancreatitis paniculatis. It's a rare syndrome caused by elevated pancreatic enzymes in the blood, leading to fat necrosis that affects the adipose tissue, joints, and bone. And as we saw in the lab value, the lipase levels were really high. So that would suggest the pancreatitis. It's pancreatitis, paniculatis, and polyarthritis syndrome is also common in middle-aged with alcohol use disorder, which was seen in this patient. So for us to establish the diagnosis of this disease, I would advise that a skin biopsy is done. And if it is positive for this disease, the biopsy will show uh, fat saponification by calcium salts with homogeneous basophilic material, also known as ghost cells, which is specific to pancreatitis paniculatis. Next slide, please. So Kingsley will continue from here. Thank you.
Oh, we cannot hear you.
I was having issues with my system. So basically, I'm talking about the pathological findings of this patient. So the skin biopsy in panel A or slide A, you can see this H&E stain, which reveals lobular paniculatis with marked fat necrosis and saponification. Whereas in slide B, reveals aneuploidy and necrocytic adipocyte with basophilic cytoplasm, which are features of coagulative fat necrosis. Next. Okay, so pancreatic paniculatis. Pancreatic paniculatis usually patient with pancreatitis, the necrotizing inflammation due to systemic release of pancreatic enzymes such as lipase, amylase, trypsin, and subsequent neutrophilic infiltration. Dystrophic calcification could also be seen in cases. Chronic changes can be included, which is outsourced inflammation and hemoptysis during deposition. Next, the management of the disease. In this patient's case, CT scan shows necrosis with walled off and coating gas, which is indicative of infection. For such cases, a mechanical intervention is done, as the first step, which is followed by invasive percutaneous or endoscopic drainage. Although in most cases, initial drainage might not be enough, so necrosectomy is performed. And the use of initial drainage is dependent on location of necrosis. Next. Although transgastric drainage is more advantageous compared to percutaneous drainage, this patient treatment could only be done using percutaneous drainage due to the site of necrosis being the gastroduodenal artery. And the degradation was due to prolonged exposure of pancreatic enzymes to the artery. So 60 to 70% of patients initially treated with percutaneous drainage will require a step up to some form of necrosectomy to eradicate necrosis and facilitate recovery. In these patients, initial drainage alleviated symptoms, resolved septic shock, and radiologically showed improvement in the size of necrotic fluid collection. Next. Yep, back. There's no standard or criteria when deciding if a patient is ready for necrosectomy. This decision just depends on the radiological progress of the patient. This patient had recurrent fever and abdominal pain after steady weeks of progress, and no decrease in the volume of the wall of necrosis. So the decision to perform necrosectomy was inevitable. Once the decision is made, the next step is to determine the technique that will be used. And this is determined by the initial stage of drainage. As seen in this case, it was the percutaneous drainage through a combination of transperitoneal and retroperitoneal routes into 3 discrete areas of wall of necrosis. Next. One of the areas was completely drained, whereas the rest of the field was assessed through relatively narrow intercostal and transperitoneal windows. Dilation technique are ideal for multifocal ward of necrosis just in this patient and can be assessed through narrow windows and transperitoneal window due to the risk of damage of surrounding structures. In these patients, as most patients with multifocal necrosis, we perform debridement of fluid in separate procedures so as if a complication should occur, isolation should be possible. Next. This patient was treated with 2 month tapering course of prednisone with a starting dose of 20 mg daily, which helped relieve suppressants in the patient's swelling and pain. Next. Thank you. Questions?
Thank you very much. So that was a case of, don't close your slides, actually keep them. So that was a case of Nikhil, Joshua, and Aniki on the patient with strange type of pancreatitis. So the first question is coming from my side. Now, would you be so kind, guys, to show me the lab values of this patient, specifically what related to red blood cells? So would you be so kind to explain me, what do you think, what kind of anemia this patient has and what the reason for this anemia, based on what we learned? So who would like to answer this question from your team? No, guys, if you don't want to, I have to assign somebody.
It can be a sickle cell anemia because the hematocrit, because of the low hematocrit.
Because of low hematocrit.
Yeah, that's what I remember. Right?
Well, no, low hematocrit is actually just marker of the anemia, right? So what you probably would like to say is that anemias, in sickle cell anemia, so the red blood cells become hyperchromic probably, or have increased level of mean cell hemoglobin concentration. So, by the way, with sickle cell anemia, so probably we'll see some sickling of the cells and hemolysis of red blood cells, so spleen changes, like atrophy of the spleen. Did this patient has all the symptoms of sickle cell disease?
I don't think so.
Did he had any vaso-occlusive crisis or in his life? And what is age of a patient?
He was 55 years old.
How long people with sickle cell disease usually live? most of them die pretty young, right? So it's really a low chance that this is sickle cell disease. So, what
Sickle
kind of,
cell.
I mean, besides sickle cell disease, what else? Any hypothesis? Sickle
Or
cell does
maybe iron deficiency, iron deficiency anemia.
iron deficiency anemia, and what possibly cause of his iron deficiency in such case? Possible. What do you think? So, how this patient potentially was losing iron if you are proposing this is the cause of anemia? No ideas, guys? All right. So remember, you need to look for the bleedings, right, in this type of patients. Maybe he has to check blood in the stool, right? So maybe occult blood test, stool blood test, right? Check whether patient has any peptic ulcers in the stomach. So because iron deficiency is very likely cause. And this patient looks like has some kind of chronic inflammatory disease. Chronic inflammatory diseases, we're causing what type of anemia? Who can recall me from your group? Right? So what type of anemia associated with chronic diseases? I'm already kind of giving out you entirely.
Anemia of chronic disease.
Bingo, absolutely right. So would it be possible anemia of chronic disease in this case? What do you think, guys?
Yeah.
Absolutely right. So long-standing chronic inflammatory diseases causing anemia of chronic disease. And anemia, in this case, this anemia is macrocytic, normocytic, or microcytic anemia.
Looks normocytic.
Normocytic, absolutely right. And anemia of chronic disease, usually either normal or microcytic. So theoretically, we more likely think about here anemia of chronic disease as a possible situation. Okay. Now, let's one question for you guys is related coming from the questions from the groups. So uh, Group 1 is asking question, what caused the necrotizing inflammation in this patient? So why this patient developed necrotizing inflammation, I think is related to the pancreas, right? What's the reason for pancreatitis in this patient?
Yeah. Was due to the prolonged exposure of pancreatic enzymes.
Prolonged exposure to what?
Pancreatic enzymes.
And why he was exposed to pancreatic enzymes prolonged? What triggered this kind of situation?
I think it's alcohol usage.
It's what? Can you repeat again?
Alcohol usage. It was a chronic alcoholic.
Chronic alcohol use. Very good. Excellent. Wonderful. Very good. So one more last question is, the question is asking what there are two questions on bevacizumab. So how does bevacizumab work? Is there any side effects of this drug?
So I think it acts by like selectively binding circulating of vascular endothelial growth factors, and so thereby it inhibits the binding of VGF to its cell surface receptor, and then I think it inhibition leads to a reduction in microvascular growth, and the side effect we see usually increased blood pressure or headaches or back pain, or we see changes in the sense of taste. Yes, that's it.
Wonderful. Okay, very good. Okay, thank you very much, guys, for